So we are here to talk.
Good morning.
It was a little bit more. So thank you guys for.
Good morning. For those of you who don't know me, I'm C.T. Lynn. I practice at the Lowry practice, just a couple of buildings down here at the university. Been here since 1995. It could be, 19 years? I used to be the new guy, not anymore. And the talk today is computing and communicating in the examination. So movies illustrate how helpful computers can be.
Open the front bay doors, please, now.
Hello, Hal, do you read me? Hello, Hal, do you read me? You read me, Hal?
You read me, Hal?
Hello, Hal, do you read me?
Hello, Hal, you read me? Do you read me, Hal? Affirmative there. I read you.
Open the pod bay doors, Hal.
I'm sorry, Dave. I'm afraid I can't do that.
What's the problem?
I think you know what the problem is just as well as I do.
What are you talking about?
This mission is too important for me to allow you to jeopardize it.
I don't know what you're talking about, Hal.
I know that you and Frank were planning to disconnect me. And I'm afraid that's something I cannot allow to happen.
Where the hell did you get that idea, Hal?
All right, so just to set tone of collaboration with our computer overlords. So I have nothing to disclose in terms of products during this talk. And today we're going to talk a little bit about new tools for using computers in exam rooms, describing at least a couple of ways to improve systems and workflows around PCs and exam rooms. And a little bit update on APSO notes. I gave a talk on APSO notes. It's been a couple of years ago now. I've got some statistics to update on. So connect, collaborate, and close. And what I'd like you to do, if you have a piece of paper in front of you, is to jot some notes of the next couple of minutes. This is an interaction between a clinician and a patient. Some of the skills are perhaps less than ideal, and some of the skills are perhaps not bad. So I'd like you to jot down what you liked and perhaps what you would change about this particular interaction. And I'd like you to be specific about your critiques.
Says here on the computer that it's been about 6 months since you've seen me. Has it been that long?
Yes, it has.
You know, we have all of your records on the computer now. That way all of your information will be right at my fingertips. Jason mentioned your heartburn.
Still got it.
Yes, I can see we talked about that the last time.
It's really bothering me again. You know, we tried Tagamet. That didn't work. The Zantac helps some, but it only takes away about half of it.
So Tagamet didn't work, Zantac only helps part way.
Right, and my brother-in-law's got the same problem. He's got a prescription for Prilosec. It feels a lot better. I'd like to give that a try.
So you'd like to try something different. Is there anything else we need to talk about?
I want to get my cholesterol checked again. We've been keeping an eye on it.
Okay, so heartburn and cholesterol. Let me check that. Let's take a look together. Over the last 2 years, you've had one reading with an LDL of 180 and another one at 160. Now, that's the bad kind of cholesterol. You're getting it down, but to be safe, that number needs to be under 130. I can see here from one of my notes that you were going to try lower cholesterol foods and more exercise. Tell me how that's going.
Well, I started walking at noon a couple of days a week, but then, you know, the weather got bad, and I'm trying to do better with my eating, but I still probably eat too much meat.
It's tough to make changes in your eating. If you'd like to keep working on the dietary changes, we have a short cholesterol class that's only 2 sessions, and we can also try some medicine now for lowering the cholesterol. What are your thoughts?
I like the class idea first. Maybe I could get my wife to go with me.
I'm noticing here on your list, your mother's diabetes and your brother's heart attacks too.
So what does that mean for me?
Well, it means that your risk is higher for having a heart attack or developing diabetes. Those are big concerns. But the good news is we can get those risks down by working on lowering the cholesterol and getting those noontime walks in on the go. Let me just check your blood sugar from last time. Computer is slowing up again. Maybe late all morning. Tell me more about that heartburn.
It's still pretty bad in the evenings, especially if I miss a dose of Zantac. It's not so bad during the day, but coffee can really get it going. And I still occasionally wake up with it at night.
Any other changes since we last talked?
No, not really.
Take your shirt off. I'd like to examine you now, and then we'll talk more about what you do next. Let me help you out. Well, your exam's normal. You wanted to try a new medicine? Right with that?
It sure seemed to work for my brother-in-law.
Let's see what pops up here. I don't know. Let's see. The computer says you can't have it. You have to. I know it's disappointing that we don't cover the medicine you had in mind, but I'd like to reassure you that the same type of medicine, just different names. I'd like to give you some information on why Protonics is our first choice over Prilosec. I can print it off the computer for you to read. Protonics has worked really well for my patients who have heartburn like you do.
Sounds like it works for most people. I guess I can try it.
So I'll order the Protonics along with the cholesterol and the other tests. When they come back, I'll send them to you if they're normal, or I'll call if they're not. If the cholesterol was as high as last time, we'll need to talk more.
I'll try to walk more and check on that cholesterol test.
You can get dressed while Jason and I are putting this together. He'll be back in a minute. Oh, and I almost forgot. I'd like you to have a tetanus shot today. I can see here that Jason was checking your vaccine records and it's overdue.
That's fine. Does it say on there when my next oil change is due?
I'm getting used to it too. I just want to make sure that we're together on what to do next. You try the new heartburn medicine and let you know how it's going, and we'll check your cholesterol and we'll talk about what we might do if it's still high. You can stop by the injection room now for your tetanus booster. It's been good seeing you. I'll be in touch.
Okay, what did you see? Let's start with what would you do differently?
Read the chart before.
Read the chart beforehand, okay? Look at the patient when? When coming in. How's that, okay?
Shut down the computer when you leave.
Other thoughts?
More eye contact with patient.
More eye contact. Introduce the computer. Anyone else?
Not criticize the computer.
Don't criticize the computer for specifically
For being slow.
right? All right, I'll open it up to what was effective. What did you like? Either one, either differently or effective. Showed the screen to the patient, the labs, for example.
Access to immunization records.
Access to immunizations. And I would say family history and some other things as well. Okay.
Facilitated communication between team members.
Facilitated communication between team members. Yes, okay. So what Jason had done before, she was able to see.
She used it for prescription checking.
For formulary checking, although that will belong on both sides of this equation because you use the formulary to tell patients you can't have it. Right? That's a lovely way of saying it. Okay. Other things.
She acknowledged that she was getting used to it too.
Acknowledged she getting used to it. Okay. All right, very good. So let's continue. Some general principles I'd like to go over in the exam room. Communication does enhance healthcare in terms of health outcomes, adherence to therapy, patient satisfaction, and indeed provider satisfaction as well, and lowers risk management. So an analysis of the depositions of patients suing their doctors for malpractice reveals that in 71% of cases, patients report a poor relationship as the reason for bringing the lawsuit. I think this is no surprise to any of you in this room. And this is general principles of communication in the room with the added complexity now of a third party, another tool, another presence in the room that could distract you from your relationship with the patient. So in the exam room, we have some general principles, 3 C's, connect, collaborate, and close, as sort of a mnemonic for how we'd like you to move through the exam with the patient. Connect in terms of establishing a connection with the patient that will promote open and effective communication. Collaborate, structuring the visit to include the patient as an active participant in the agenda setting, the events and decisions that occur during their time with you. And then finally, closing, ending the visit so the patient has a clear understanding of any decisions and is confident that his or her needs will be met. So a little more detail about connect. So greeting. So what we're going to do is go through a number of tools. And in your handout on the last page, there's a set of skills as a checklist that we all like to think that, of course, we do all of these things perfectly. And to this day, if I look at the checklist, there's always something I could be doing maybe a little better with the patient. You might use this as a refresher for tools that you can use with patients to try to improve your connection and the use of computing in the room. So greeting the patient by name, introducing yourself while making eye contact. That's something that this particular physician did not do as she walked right past him to the computer. Introducing the computer to the patient, and then acknowledging patient's companions to negotiate confidentiality. Because it's on the screen, if you're by default showing the chart, did the patient intend for you to have their driver see all of this stuff about them? So some sample words you could use. We have the computer in the room so that you and I can get the information we need to make decisions together about your health care. And then another statement, I see your mother has joined us for the visit today. Most of my patients prefer that I not share private information on the computer screen without their permission. How does that work for you? So setting a normalization statement that normally it's okay to say that you don't want to share the information with your family member rather than putting the burden on the patient. Hey, you don't mind if I show your HIV results. You want to go the other way and say, normally I don't share this without the patient's permission. And it's up to the patient to say, no, it's fine. My partner and so forth can look at the screen. Verifying information, so positioning the screen for patient viewing, referencing electronic information, verifying the patient's reason for the visit, and building an agenda together. In only 43 of 302 clinical encounters did doctors explain their use of the computer in the exam room. Afterwards, patients who received no explanation frequently reported thinking their doctor had been doing work unrelated to the visit. Also, arranging the exam room so that the screen, the patient, and you form a triangle. This way it can be easier to maintain eye contact, which should occur at least a couple of times per minute during the encounter. There is research that indicates that using videotape analysis of provider-patient interactions, that clinicians who at baseline are excellent communicators, if you give them additional tools, patient satisfaction, provider satisfaction actually improves. Those who were deemed in this research study borderline or poor communicators, you add a third complicating factor and satisfaction plummets. It's a fallacy to say, well, just with more practice things will get better. Clearly there's actually a divergence in behavior and a divergence in satisfaction unless we do explicit sort of training around this third party in the room. Oh, and then just talking about the triangulation. So unfortunately, in many default clinic exam setups, the patient's exam table and many of the chairs are far away from the device. And what's worse is that we don't give our medical assistants any specific training on where to place the patient. And so commonly, even today, I'll walk into the room and the patient is sitting in the least friendly seat. And rather than accepting that wherever the patient is how you'll have to deal with it. As many anecdotal stories of why computers are terrible have come to me, is that the patient's been has been put down in a chair, has been placed in a chair far away from the computer, and consequently the physician is yelling questions over their shoulder because they're trying to do charting at the same time. Realize that you're in charge of this geography. Why not rearrange it so the patient either sits adjacent to you watching the screen, or if that's not as comfortable for you, having them sit in a triangle that you're looking at both the screen and the patient, and frequently being able to turn the screen and inviting patients into the interaction with the computer. So collaborating, using electronic data from the computer to let patients know that you know them, talking about recent visits, talking about their prescription history, their social or their family history, and about upcoming appointments. I can't tell you how gratifying it was for me at one point to have a patient with whom I've been struggling with their A1C and their weight, and describing the numbers, and then finally being able to show them a graph where their dot was always above the red line. And the patient would say, well, wait, I'm above the red line. That's bad, right? Finally, you get it. So being able to actually show them their data in a context that makes sense to them. Some people are visual learners, and up until then, I've been trying to use audio channels to try to get through. Collaborating, making bridging statements, verbalizing what you're doing. For example, I'm looking up the record of your blood pressure to see how the medication has affected it. So often, clinicians will turn to the computer and silently tap away or click through things, and the patient's sitting there going, what, are you working on your grocery list? What are you doing up there? Asking permission to write as you talk. If it's okay with you, I'm going to make some notes so we can, while we talk, so I can be sure to remember some important points. In fact, with our current record, we have a section of the chart called patient instructions, and very often during the visit, I will be adding information into patient instructions, and I'll tell them, what I'm writing down now, you're going to get a copy to go home with. And so instead of them taking out a pen and trying to jot down the names that I'm talking about, I say, put your pen away, I'm writing this for you. And sometimes that can be very powerful. And then finally, avoid complaining in front of the patient, as you saw in the video. The good news is we have this computer system. The bad news is sometimes we have to give it time to think. There's research indicating also that clinicians who complain about the tools or the computer in the room actually reflects both poorly on on the computer, on yourself, as well as the organization. So be cautious about who you drag down with you when you're unhappy and venting, because that does impact patients' opinions about you as well. Sharing data, inviting the patient to view the information on the screen, inviting the patient's thoughts on what you view. In interviews of patients whose doctor used the computer in the room, none of the patients were able to were able to see the screen felt disturbed by it. In contrast, patients who felt disturbed attributed it to being kept out. Other words, let's look at the screen to see how your blood sugars have been since you've lost weight. I'm interested in what you make of it. So allowing patients to make their own conclusions and having a discussion about the data they see rather than necessarily packaging it for them. Sharing decisions, using information on the screen to share decisions with the patient about pharmacy choices, perhaps more nicely worded than the computer says you can't have it, but very often now you'll be able to see formulary data. You'll be able to see, in fact, I saw a patient from Wyoming, it's been a few months ago, who came and said, I really need a refill of that one pill that's so important for me. My doctor told me never to run out of it. Well, what is it? I don't know. And I was actually able to use the network and have it show me that from the Wyoming pharmacy, even though this is a brand new patient, this patient's on APSO, 20 milligrams, and so forth, and be able to use that tool. And then treatment options. So as I enter your heartburn prescription, we have a couple of choices. Would you prefer A or B? And you can even get to the point of talking about this is tier 1, likely to be a lower copay for you, and then have a shared decision-making moment around that. Closing. Reviewing the visit with the patient, summarizing patient concerns, reviewing plans, soliciting feedback. What did you think of this? Answering any remaining questions. Securing the computer, as you see that the provider did not do in the video. You're logging off to their privacy and being able to actually say, I'm logging off and securing the computer so that your clinical information remains private. And then saying goodbye, turning your body to face the patient, explaining to the patient what to do next, saying goodbye person to person. And I think this clinician actually did a nicer job closing, except for securing the computer, other than aside from coming into the room. Okay. So here's a different demo of how it might look differently.
situation, have you? Seems like it's been a while since you were here last. So what's been going on?
Not much. I've been still teaching a few piano students, even though I retired from full-time teaching about a year ago.
I remember you got a new grand piano last year.
That's right. Oh, it feels so good. And the sound is beautiful.
Well, speaking of keyboards, we now have all of your medical records on the computer now. That way all of your information is going to be right at our fingertips. Now, Jason mentioned your heartburn. Okay, so heartburn and cholesterol. Let me check that. Let's take a look together. Over the last 2 years, you've had one reading with an LDL of 180 and another one at 160. That's the bad kind of cholesterol. You're getting it down, but to be safe, that number needs to be under 130. I can see here from one of my notes that you were going to try lower cholesterol foods and more exercise. Tell me how that's going. Well, you can get dressed while Jason and I are putting this together. He'll be back in a minute. Oh, I almost forgot. I want you to have a tetanus shot while you're here today. Jason checked your vaccine records and it's overdue. But to finish up, I'm just going to log off the computer so that your records stay protected.
That's fine. Does it say on there when my next oil change is?
I know what you mean. I'm getting used to it too. I just want to make sure that we're together on what to do next. You try the new heartburn medicine and let me know how it's going, and we'll check your cholesterol and we'll talk about what we might do if it's still high. You can stop by the injection room for your tetanus booster now. It's been good seeing you. I'll be in touch.
Comments on that? Looks a bit different, but it's the same tool, and with minor adjustments, you can make this a much more straightforward interaction. So, exam room computing, step by step. From having given this talk at a number of other locales, it's clear that clinicians are on a bell curve for where they are with using computers in rooms. I am still familiar with clinicians who unplug the computer in the room and insist on going back to their office and looking everything up and then coming back into the room to see the patient. For those clinicians who are uncomfortable using the PC in the room, that could be a more safe behavior, but it does add minutes to your day. So I thought I would go through sort of a step-by-step for where self-diagnosing in terms of where you are with using computers in the room and trying to step it up to the next level. What could you do? What more could you do in the room that would both improve your satisfaction, get you done a little bit sooner during the day, and improve clinician and patient satisfaction? So for those who don't use a computer in the room, you might add reviewing clinic notes the last time you saw the patient, perhaps the last time the specialist or consultant saw the patient, labs, meds, radiology films or results in the room, showing graphs of the lab or the blood pressure or the weight of the patient can be a first step. If you're someone who does only lookup and then creates orders and notes later, you could start writing a prescription or two, renewing a prescription, writing a lab or radiology order for common illnesses. And then if you do place some limited orders, the next step up might be creating and using templates for 1 or 2 common diseases, maybe upper respiratory, maybe cough, maybe UTI would be something that you could be comfortable trying out in the room when you see patients with straightforward illnesses. And then typing scratch paper notes for cleanup later. I know that in the days before electronic health records, I used to violate HIPAA. Well, this was before HIPAA, right? All the time, I would take charts home in the trunk of the car and dictate them and finish them late at night, bring them back in the morning, if I remember to bring them back in the morning. And I would commonly have pieces of scratch paper attached to each chart with the scribbles of, CP, SOB, 3W, those things that I remember would be enough for me to have a framework from which to dictate later, or from which to construct a full note later. And why not use the electronic record in draft mode, because nothing is permanently saved. You can fix it later. And I will now use the HPI section of the note to not have a beautifully rendered full construction sentence. I would put 3W, CP, SOB, next line, and try to have a framework there so later I can erase it and put in the full note. And by the way, I'm not taking scraps of paper home with protected health information to dictate from or to complete later. I can log in everything that I've written about the patient, even in draft form, is still there. So if I write part of the notes, these are other things you can do. Touch typing lessons, dramatically ease of use. this is perhaps not an issue for those in this room, but I've given Mavis Speak and teaches typing to innumerable colleagues throughout our organization, and it is true for those clinicians willing to go a few rounds with Mavis that being able to touch type rather than staring at the keyboard can dramatically ease that use. Dictating in the room to save time. I know of a number of orthopedists, for example, who, without the requirements of daily billing, because this is global fee billing, they can turn on their dictaphone and mumble into the phone in front of the patient. Patient comes back for a 4-week check, wound looks fine, elbow's got full range of motion, next visit, x-ray, 2 weeks, click. Okay, any questions? Next. So you can do that in the room, and boy, wouldn't we love to have a short visit like that, but that's something that's potential as well. Speech recognition in the exam room, there's a story I like to tell. I haven't used this in great detail, but I've actually brought my own device into the exam room, and having installed the Mac version of Drag and Dictate, tried doing this in the room. And I have to tell you, it's a mixed bag at best. In the HPI section of the visit, it's horrible, because you have the headset on, you look like a little bit of a robot, and then you're talking to the patient, and then you want to say what you heard to the computer, and so you'll say, Mrs. Smith, please stop talking, I'm going to talk to my computer. Mrs. Smith is a 45-year-old Caucasian woman here, follow up with da-da-da-da-da, and her, and while I'm saying that, the patient's going, no, not my uncle, my grandfather. Yeah, and I'm going, stop. Oh, your words got in here. So you have two voices being recognized, and it's really not ideal. And I find that it's not conducive to building a story, because unlike with touch typing, where you can maintain eye contact, and who cares if you misspelled it, you're still getting down, basically stream of consciousness, what's coming out of the patient's mouth. You're having to actually interrupt that flow and say, stop, I have to record some of this because my brain is full, I can't remember all of it. So I find that touch typing far superior to speech recognition for the HPI section. Now, I have a very different opinion about assessment and plan, because by that time, it's a monologue for me anyway. And the monologue at this point is as slow as I can type. Hold on, backspace. What I would like you to, backspace, to do is to, backspace, increase your atenolol to 100 milligrams, and I would love to be able to, and actually those times that I did this, I was able to say, Mrs. Smith, it's going to sound a little weird coming out of my mouth because I am talking to the computer, but you'll get a gist of what we're going to talk about. Click, microphone on. Mrs. Smith, we talked about several things, period, new line, numeral 1, hypertension, period. This is under excellent control. However, I'd like you to increase your lisinopril to 20 milligrams, period, new line. You can actually speak at that pace, and the computer will catch up to you and be in the range of 98, 99% accuracy. And then you're looking at the patient while you're doing this, and when you click off, you can say, did that make sense to you? Here, I'm going to print a copy. So that, I think, can work spectacularly well, and we're hoping to be able to deploy Drag and speech recognition this year at the university. We've finally gotten funding a decade after I wanted to do this, so we're going to start rolling this out. You can also further customize templates for efficiency in terms of adding on to, instead of just the common illnesses, you can develop additional HPI or plan templates for things you commonly see. Print the assessment and plan or the complete note for the patient, and then I know some colleagues who actually complete their billing as the patient leaves the room, so you're completely done with this patient encounter as the patient's done. So I think that's the rare clinician who does so, but as a group of clinicians on a bell curve, there are some folks on the far right of the bell curve who are very efficient with these visits. Questions about that so far? Comments? Yes, please.
Just to reiterate the touch typing, I also am touch typing. I'm far end of the curve there. I do complete 95% of my notes done. But one of the nice things about it is about how my grandfather, my father, is that I actually when I type, I'll talk to the patient and I'll say, now let them talk and ask the questions. Okay, I want to get this down, and I'll just essentially start typing it and just dictate what I'm actually typing.
You'll say it as you're typing.
I'll say it as I'm typing it and say, is that your left or your right? If I'm right, okay, then I can correct things as I go because I'm actually doing it.
Thank you. So in those of you who've been through the Foundations of Doctoring course, we actually do recommend highly the idea of reflective listening, and this is reflective listening with the computer. So in addition to saying it back to the patient, what you're doing is you're typing back the salient parts, salient parts of the patient's history anyway, so why not record it while you're talking about it? So it's double reinforcement. And should you wish to, you can give the patient a copy of that to go home with to say, see, I did hear you correctly when we made this decision. Okay, thank you. So moving on to a little bit about APSO notes. For clarity, I've for about a decade now printed out, even before our EPIC electronic health record, I printed out draft copies of the patient's partly completed note, and that benefited from having an assessment and plan written at the top of the progress note. So this is just a little bit of introduction to APSO notes in general. The idea that instead of having illegible scrawl, we now have typed notes, which are not illegible, but some would complain unreadable. So if you were to look at this emergency department visit, actual visit, tell me what this patient had. And I'll help you. Attending differential. The patient does not have systemic illness, toxicity, significant dehydration, hemodynamic instability, sepsis, SIRS, and you're thinking, this is useless. And it's not until you get to the second paragraph where you go, oh, actually, here it is. 64 with recurrent bladder hemorrhage, now with second obstruction, Foley placed yesterday. This did not even exist at the top of the note until we insisted that, quote, your ER notes are unreadable, please do something about it. And we didn't actually have them start to put visit summaries at the top of their ED notes. This was before our EPIC system. And so you would think, well, that's not so bad. It's only the second paragraph down, and how bad can it be? Well, no, that's just the first screen out of 15, 16 pages of data, and really don't miss the salient parts on page 13, page 4, page 3, page 1, right? So just because you type it doesn't mean it's better. So too many customers for a provider's note, and here's the physician author, and here far away are other physicians trying to understand what you're trying to say about this patient. So if we're not careful, this is what we end up with. So one potential solution is to reformat your progress note from a SOAP format, S-O-A-P, to APSO, assessment and plan, subjective, objective, where you put the billing, compliance, and regulatory items last, and then collapsing things down to the front. So yes, so what if it's 17 screens full of data? The clinician can really stop reading at the end of the first page. That's the intent of this design. So the theoretical risks and the benefits: no scrolling to find the conclusion, quicker to review many notes, less likely to miss critical info, easy to print a partly completed note. Colleagues and patients find APSO easier to understand, and APSO takes no longer than SOAP as an author. The risks, and I've heard more than my share of the risks. I was told, I don't know where you trained, but I don't know of any clinician who walks into the room and says, Mrs. Smith, good to see you. Now, I think you have diabetes. Let's talk about why you're here. And then that's completely in reverse. No, that's not true. SOAP is how I think. SOAP is how I train. APSO is not logical. It may cause confusion. And especially with an electronic record and a formatted note, you can jump down, and yes, you can still do SOAP in the sequence that you were trained to do it, but that your note is finished in a different format. And then, of course, change is bad. The only person who likes change is baby with a wet diaper.
That's not always good.
Good. So actually, from a research study I did a couple of years back on satisfaction, the orange bar and the higher up is better. Those who, as an author, thought that writing in APSO format, this was 84 providers, 2/3 of them in primary care, 1/3 of them in specialty here at this organization. And those that felt like writing in APSO format after we had trialed this for a few months was very easy or easy. It was about 70% positive, about 18% neutral, and very few thought it was difficult or very difficult. In terms of the time, on the top right, that it takes to write an EMR note, the vast majority of folks thought it was neutral, really not different between APSO versus SOAP. And then as an APSO author, satisfaction was quite high, also in the 70% range, compared to neutral, and compared to 4% who were dissatisfied. And then in terms of reading notes, again, very high satisfaction. Orange and blue bars were much easier or easier with APSO notes in terms of finding clinically relevant data. And then as a consumer of notes, very satisfied with the APSO format, was in the 80% range. So, and this is actually held true. This is how the note looks in our electronic health record with the assessment plan at the top of the note when you look at it. And so consequently, as patients develop more history with us, and I have several patients with over 1,000 entries in their notes section, Can you imagine clicking and scrolling down to near the bottom to look at the assessment plan for a sequence of more than 2 or 3 notes? You get tired and you'll say, I'll just ask the patient, and it's too hard to find. Whereas with the assessment plan, if it's the first screen full of data that you can see, it's much easier to flip back through the continuity of dozens, potentially, of notes to find out what's happened to the patient in the past couple of years. Having redone this survey more recently, only about 3 months ago, throughout our health system, we've expanded from being 1 hospital now to being 5 hospitals, and expanded from about 50 clinics to about 300 plus clinics across all of UC Health. And our utilization of APSO notes, since the best way to have a change is to have a burning platform and pull the rug out from under folks and say, well, if you want to use Epic, really the only thing we have is APSO notes. Sorry. It's just designed that way. So aside from the fact that there are some clinicians who know how to stomp their feet and say, I'm not changing and you need to make a reversion for us, we're on the order of 98% of primary care docs using APSO notes, and among our specialists, we're running in excess of 90% of our specialists doing so, again, with high satisfaction for the vast majority of clinicians. Right.
When can we change the ER so that they will be on APSO notes and we can figure out what the hell happened?
That's an uphill climb. Some clinicians are in the ER doing this, but it's certainly not universal. Yes?
With whatever the last recent update in terms of the assessment plan options, it's very easy to get away with not typing anything, and it just has your list of diagnoses and the list of disorders that are associated with it. So while it's nice that it's at the top, about half the notes that I read have almost no words in the actual assessment plan, which makes it almost impossible to interpret what somebody else was thinking. Has there been thought to bringing back like some sort of mandatory, you have to write some sort of text to explain some sort of thought process in the assessment plan?
So the comment is that with the assessment plan structure as it is, it's easy to just skip having any thoughtful discussion of your formulation of the patient, rather than just have a list of diagnoses and move on. There are clinicians who, even before APSO, would write nothing other than a list of diagnoses, and so it's sort of a translation, and can you necessarily make a silk purse? But on the other hand, there is a question of, do we want to make it more explicit and put a hard stop here and say you have to put in a formulation? And so we did have a discussion. It's been a couple years ago now, where we had a hard stop right after the assessment plan, where it said, what is your plan? And you couldn't finish your note without typing something there. I imagine folks could hit the backspace and ignore it anyway. So it is a debate between efficiency, which is not put in additional hard stops when they're unnecessary, versus saying this is a big enough systemic problem that we do need to put something there. So that's certainly something we could have a conversation about. It's very customizable. It's just be careful what you ask for when you do so. Other comments? Okay. I'm going to move on. Extenders, scribes, and quick sheets. So this is quite the discussion these days about what other ways could we improve the exam room interaction between clinician and patient. Currently at UCH, we have medical assistants who capture chief complaints, allergies, smoking, pain, fall risk, vital signs, all these Joint Commission requirements. And in some practices, they perform medication reconciliation, even a limited history of present illness, guideline-driven labs, vaccinations, screenings, referrals. We could also insert a nurse into the workflow to adjust hypertension, cholesterol, diabetes, warfarin medicines, provide education, then leaving for the physician, for example, to review the work of the multidisciplinary team, evaluating new symptoms, answering complex questions rather than the routine. And I know that we are looking at the family medicine practice at Stapleton, and also one of our UC Health partners up north, to pilot what's called the Utah model, where there's less placed on the clinician for documentation. Routine stuff is taken care of ahead of time, so the clinician can then focus on what's really the challenging work of the clinician. So that's coming. I know that many practices are sort of looking at these models. And an electronic records tool does allow you to share this work. It's just a matter of making sure we don't run afoul of billing or compliance or regulatory items in our design as we move in this direction. Scribes, which I think the only place in our organization we use scribes in the room is in the emergency department. By regulation now through the ED national organization, they restrict scribes to documenting narrative for the visit and not placing any orders. So the scribe can do HPI, past medical, review of systems, physical assessment and plan as the clinician's talking about it. Now, unlike this item here, the ED role does not allow scribes to place orders. It's up to the clinician to cross-log in, place those orders, and log out. The scribe can, and the clinician can countersign either on the same computer or on a separate laptop as they're carrying it around. And at least in primary care practices, there has been some demonstration in some practices that 2 or 3 more patients per day can pay for the cost of the scribe, and the documentation is more timely, and there's increased physician satisfaction. So there are some organizations that are looking at this particular model. There are downsides of using scribes, as a scribe is doing this, responding to alerts can be mitigated, and if the clinician's not careful and ignoring the screen while the scribe is seeing the alerts, perhaps you would hope that the scribe is passing along the alerts to the clinician to respond to, but there is some literature indicating that the effectiveness of best practice alerts and interactions to the scribe don't necessarily make it to the clinician. So now you can start to ignore the benefits of an electronic health record by putting another person in between the workflow. Be careful what you design. This is a lesson from my deep, dark past. Some of you may remember quick sheets and the fact that we had designed a way of abstracting relevant data for the clinician at the time of the encounter in terms of reminders. We actually built this with a company called CINA, where on the left side we have the current list of the medicines from the patient pulled from the electronic record and the active diagnoses, and on the right side, actually further down in the sheet, there's even vaccination records, cancer screening items, last date of, and on the right side there would be recommendations. Hey, there's some risk factors, there's some goals for the patient, and there's some action items. Some action items were designed for nurse or MA. Hey, the patient's due for a flu shot, they're a candidate and they haven't received one. Or there are action items for the clinician. Hey, do you want to diagnose syndrome, metabolic syndrome in this patient because they meet criteria? And we had some practices do a great job with this, where every morning they would distribute it, they would think about it, they would have huddles, they would pre-check the items, and days would be more efficient for them. And unfortunately, we had underappreciated the workflow behind this, that when we developed this for the family medicine practices and distributed it to other practices in primary care, most practices took the sheet of paper and put it in the trash, because who's going to do this? Do you not think I'm working hard enough already? So it's not necessary that a tool that was thoughtfully designed will actually necessarily be successful unless you put some thought behind who's going to do this, whose job is it, where does it fit in the workflow. So to conclude, that it will ever come into general use notwithstanding its value is extremely doubtful, because its beneficial application requires much time and gives a good bit of trouble both to the patient and the practitioner, because its human character are foreign and opposed to all our habits and associations. If you've seen this quote, please don't say it, but what do you think this is about?
Hand washing.
Stethoscope and go for it. Thank you very much. And I'm open for questions.
So thanks for the talk, CT. And I think, so after 6 years of using Epic, 5 or 6 years now, as an 80% clinical person for those 5 or 6 years, I hope I'm somewhere on the right side of the bell curve by now. And I think over those 5 or 6 years, it's improved my efficiency and maybe my patient communication as well. But one of the things I'm wondering about, and this might be a question that you're not involved with, but we were sort of mandated, we've been through 3 different systems since I've been here, and have had no individual coaching or instruction on how to, I mean, this talk is really helpful, but I think given that we're all on a bell curve, some of us are only in clinic a half day a week or 2 half days a week. I mean, this is important for our patients, it's important for our job satisfaction, it's important for our efficiency. And the university has invested no upfront time in training their clinicians individually on how to be better at this. So I'm wondering if that's something that has ever been thought about or in the works or anything like that, especially if we're moving to scribes and things like that, which will be a whole nother different system.
So the question is about individual clinician coaching or training in the use of a tool such as this. And I would agree that the organization has not been at the level of doing individual coaching other than occasional talks that I would give on these sorts of general principles. I know that, for example, Dennis and Kopic have been out there giving workshops on this sort of thing with community practice physicians who are insured through Kopic, but we've never put together an individual coaching plan. I know that we've talked, this is back when I was medical director of what now is Lowry, that we talked about putting a videotape in the room and videotaping clinicians periodically to survey their overall interaction skills, much less the computer interaction skills. This is really part of a larger conversation of how do we interact with patients and what is our satisfaction like. We actually did offer to teach a 4-hour workshop for all 600 clinicians on campus. I was part of that initiative back when the general principles here were laid out by the Bayer Institute. That was a nonprofit arm of Bayer Pharmaceutical Company that was dedicated to improving healthcare communication. We have a dozen faculty who are institute trained to give 4-hour workshops on communication. We offered to give this for free across the institute because at the time, across the organization, because at the time we were in the bottom quartile of physician satisfaction for patients back in the late 90s, early 2000s. And the pushback from the medical directors and the department chairs was, 4 hours is a lot of time to take clinicians out of practice. And by the way, I don't believe your p-values are that, they're not true. We're good doctors here, don't bother us. So we actually offered to do this sort of training and were turned down by the leadership because this is not something important to invest in. So, I don't know, Eva, you have any other comments on this?
It's sort of changing. The HCAP scores and the new service excellence team see this as a major problem. Doug Jones, myself, and the hospital leadership have had several meetings about this. There is going to be a pilot this year, but again, it's voluntary. There has been no willingness from the group to require this, and there's some conversation about whether we'll require it for new hires and then offer it to others. So that piece of it is still challenging, but it's moving sort of at the pace we expect.
But we would be happy to participate in terms of adding the curriculum from this third party in the room into such an effort. But we've tried various times, but not recently, to do that. Maybe something we could resurrect. And if we want to do that for the department or the division, happy to help construct something if there's interest in doing so. Mark.
You mentioned dictation a couple of times in Dragon. So is Dragon set up so it will directly, you actually see it appear in the note, or does it create elsewhere and you have to import it?
Yes and yes. So the question is about Dragon, and like I said, there is finally funding this year to deploy Dragon. We'll be starting with the emergency departments to try to improve readability in those notes. But what happens with Dragon is there's two ways of setting it up. You can actually dictate and the words will appear right in your Epic progress note as you're speaking. Some clinicians find that the correction tools are not as good when you're using it right in the electronic health record, and they prefer to put it in a separate window where you can copy and paste it very quickly once your paragraph is done. So clinicians do it both ways.
And that will be deployed enterprise-wide?
So it is not a simple thing to do enterprise-wide. We have a pilot of 600 licenses, which is 1/5 of all of our clinicians. We have 3,000 doctors across the health system now. But we're looking at our high-volume dictation clinicians, and I imagine, Adam, you'd be in that. I don't know if you dictate a lot anymore. So those of you who are high up on that list will have some of that offered to you this year, and then we'll be looking at adding additional clinicians. But it is not yet a system-wide license. It's not an inexpensive thing. It's $2.5 million to have an enterprise-wide license. So, but we're moving in that direction. Okay, thank you very much.
Your kids know you have that slide. My kids are never forgetting that. That was a great talk.
Yes. as we're looking at the